Hello, my name is Julie Ballas. I'm the Joint Care Coordinator at Trumbull Memorial Hospital. I'd like to welcome you to pre-op class. We call ourselves the Center for Joint Replacement Surgery. Rest assured, you're in good hands. We have an award-winning program. We're the second program in the United States and the only program in Ohio to achieve advanced certification by the Joint Commission. We're also a Marshall Steele partnership. There's only 200 such programs in the United States, and once again, we're the only hospital in Ohio that can boast of that. We also are distinguished by Anthem Blue Cross Blue Shield as a Center of Blue Distinction Plus. So if you didn't notice, walking down our unit, we actually have a theme to our floor. We have a vintage travel theme, so each room is a different travel destination, and we have various travel paraphernalia throughout the hall to make it a little bit enjoyable and a fun experience for our patients. I like to say that it takes a small village to take care of a joint replacement patient. This is a picture of just a few of the many people you'll get to meet when you come and have your surgical experience with us. Every one of these people and many more will care for you in one way or another during your stay. So why do we do class? Everything that we do in our program is based upon evidence-based practice and research. Research actually shows that when patients come to class and are educated before surgery, they have a better surgical experience and they exhibit much better outcomes after surgery. So what we're going to talk about today is how to get ready for surgery, a little bit about the surgery itself, what's going to happen during your hospital stay, and what to look forward to in your rehab phase. So for those of you who are knee patients, let's talk about the anatomy of the knee. When we do a knee replacement, there's 3 bones that we work with. On the picture on the left, you'll see your femur is your thigh bone up above. Down below is your tibia. And then that oblong bone in the front is what people call your kneecap, or what we call your patella. If you look at the middle in the right-hand view, you'll see that lining the ends of those bones in the back of your patella is that white surface. It's articular cartilage. It's a nice, smooth, slippery surface that's there so that hinged knee joint glides real nice and easy over itself. If you're one of our hip patients, up at the top of your femur is your femoral head. You can see that round ball in the right picture. And then in your pelvis, the cup is called your acetabulum. So the hip is a ball and socket joint, and it's the same thing. Lining that socket and that ball is that white articular cartilage. It makes it nice and smooth and slippery so that ball glides real nice and easy over that socket. So what happens when you get osteoarthritis, we like to call it wear and tear arthritis. From the constant wear and tear, that cartilage starts to wear itself away, sometimes to the point that the bone is exposed. You can see in the pictures on the right. So you kind of go from a nice, smooth, slippery surface to a more rough surface. It's your bone edges that are kind of going to be grinding against each other. And you can get osteophytes, or what people commonly call bone spurs, that you see there. And so what that does is it inhibits your movement and your range of movement. It causes pain. It starts to make noises when you move. And that's usually when people go to the doctor and say, I think I need some help with this. So if you look at the x-ray on the left-hand side, people don't realize that when we do joint replacements, we put your body back in proper alignment. Between those 2 bones, you should have a space, and that represents your cartilage there. And you can see how that patient has totally worn that away, so those 2 bones are just grinding against each other. So if you look at the middle picture here on why you need surgery, your body was actually designed to be in a line from the center of your hip to the inside part of your knee to the center of your ankle. And what happens, especially in our knee patients, is when you start to wear that away one way or the other, our patients start to become either bow-legged or knock-kneed. So you can see the slide with the varus and valgus. That's what the physicians or the medical terms are for bow-leggedness or knock knees, how that can take and wear away on the inside or the outside of the femur and the tibia and start to cause those deformities in patients. You can also see after the surgery with your joint replacement how we've put you back in proper alignment from that person being so bow-legged or so knock-kneed, and then you look at the x-rays afterwards. So that's what we're talking about. We're going to give you new joint surfaces, but we're going to put you back in alignment. So what do we want you to do beforehand? I like to tell people it's like having a baby. You don't want to take a baby home and not have a nursery ready to put it in. So you want to get your house ready before you come to surgery. So number 1, we like our patients to go directly home after surgery. You're usually going to be in the hospital only 1 to 2 days after surgery. So please get your house ready ahead of time. If you live alone, make arrangements for somebody to come stay with you, or go stay at somebody's house that preferably has like a 1-level house. We like our patients, like I said, to go go directly home after surgery. We also want you to take a dry run through your house. If you have that walker, go through areas of your house and make sure you have a nice, clear, wide path. Your kitchen, your bedroom, your bathroom are the most commonly used areas of your house. Make sure that you have that clear path. If you have any throw rugs, get them up and out of the way. Any electrical cords that could cause you to trip, things like that, you have to kind of, look at ahead of time and make sure that you have that nice wide path. In your bathroom, if you're one of our hip replacement patients and your doctor uses hip precautions, it might be a good idea to invest in an elevated toilet seat. Some of our patients go home on hip precautions, which means number one, when you sit, your hips should never be lower than your knees. So that's something that you can assess and take care of beforehand. We also want you to choose a chair at home, a nice chair where you're going to sit at a nice right angle and not sink way down into it, that has arms. We'll teach you how to go from the arms of the walker to the arms of the chair to get in and out of the chair. In your kitchen and your bathroom, take and assess that and look at it, and if there's things that you keep under the counters or at a low level in the kitchen or bathroom, move them up to at least hip level or countertop level. Say if I was a gentleman and I shaved every day and I kept my shaving supplies under the sink, move it up to a higher shelf in the bathroom or on the sink countertop so that you can get to it as easy as possible when you go home and be as independent as possible. And if you're a cook, like I said before, you're going to go home on some narcotics. You want to get easy to prepare meals, things that you can make and it only takes a couple of minutes to make, but you have a good nutritious meal. You're not going to want to go home on narcotics and make a Thanksgiving feast for everybody. Things that we want you to bring with you when you come for surgery. Our patients only wear hospital gowns the day of surgery, so we ask that you please bring at least 2 t-shirts and 2 pairs of shorts, or like stretchy capri pants, something like that. Our patients exercise together every day in a group setting in front of other patients, so we want you covered for modesty's sake. Plus, it kind of promotes that feeling of wellness. You're a healthy patient from the time you come out of surgery, and we want you to recognize that, and most patients feel better when they're in their clothes from home instead of that old, stiff hospital gown. We also ask you that if you want to bring any makeup, shaving supplies, toothbrush, toothpaste, anything like that, you're welcome to bring that along with you as well. We use a coaching concept for our patients. Same thing as when a lady is having a baby. We ask that you choose a motivating family member or a friend that's going to come and learn your physical therapy and learn all your care right alongside you. We ask that coach be here at 9 o'clock in the morning the day after your surgery. We want them to go to group physical therapy with you and have group lunch and learn your care so that when we turn your care over to them in a day or two, they're going to be comfortable taking it over. If any other visitors want to visit you, we ask that they wait till after 3:30 because you're not going to be in your room to visit with them. You'll be back doing your group therapy. The roles of the coach are highlighted here on this slide. It's just basically for encouragement to learn your care while you're here, learn your physical therapy, learn all of your discharge instructions, and families really like that we do that because they become comfortable when we transition them to care at home so that they can take that over for us. We swab everybody for MRSA before surgery. The reason that we do that is everyone carries Staph aureus, is an organism that resides in your skin and in your nose. A small percentage of the population is a carrier of what we call methicillin-resistant Staph aureus, which is what those letters stand for. We'll swab you when you come for pre-testing, and if that comes back positive, your surgeon will call you and put you on some medicine that you'll put in your nose for 5 days in a row, and they'll also have you take additional night before surgery washes. When you come, we'll actually do your shaving your prep and your surgical prep with the same soap to knock as much of that staph off of your skin as possible before surgery. Regardless though, when you come for pre-testing, our nurses will educate you and give you a handout and a special bottle of soap that we want you to wash with the night before surgery and the morning of surgery. We ask that you sleep on clean bed sheets and in clean nightgowns or pajamas before you come to surgery. It's one of the things that we do to help prevent infections, and we're very proud of our 0 infection rate. Our pre-op testing, we like to do at least 21 days before surgery. When you come, that'll be about a 2-hour interview with a pre-testing nurse. She'll do an extensive history and physical, a multitude of screenings, and they'll do some education, give you your Hibiclens soap, teach you how to take deep breaths with our Inspirex, do a couple of things on your pre-op education for you. We'll also talk about the anesthesia that you'll have. The majority of our patients have what's called a spinal with sedation. Research actually shows that this is the best for joint replacement for a multitude of reasons. If you have any qualms about having a spinal with sedation, you can talk to anesthesia the day of surgery. The second option is general anesthesia. The beauty of having a spinal with sedation is it actually is the best for joint replacements for a multitude of reasons, but you'll actually still be breathing on your own through an oxygen mask. You'll have spinal anesthesia, but they sedate you to the point that you're sleeping. You don't know or see or hear anything in that room or care about what's going on. When the nurses interview you during your pre-op testing, they'll ask about every medication that you take at home, and they're going to go through that list and tell you which medicines they want you to stop and which medicines they want you to continue. If you take certain types of medicines like blood pressure medicines, seizure medicines, things like that, they may even tell you to take 1 or 2 pills the morning of surgery with a tiny sip of water. We ask that at midnight, the day of your surgery, that you do not eat any solid food after midnight. That includes gum, lifesavers, sucking on mints, anything like that. We will allow you to drink clear fluids up until 2 hours before your surgery. So if they tell you they want you to be here at 7 o'clock in the morning, you can drink clear fluids up until 5 a.m. Clear fluids is like water, clear or light colored Gatorade. That does not include coffee or tea. Everybody should be taking a multiple vitamin with iron. Depending on what your hemoglobin level is, when we draw your pre-op lab work, your doctor may call you and put you on ferrous sulfate, which is an iron supplement. What iron does is it helps your body build up its own red blood cells before surgery. So that's something that if your hemoglobin is a little bit low, your surgeon may call you and put you on. If you take any types of blood thinners, Coumadin, Plavix, Xarelto, Eliquis, aspirin, anything like that, your surgeon or your medical doctor will work to stop that before surgery. Obviously, we don't want you to bleed more while you're back in surgery. If you take any type of herbal medicines, and there's a million of them out there, we ask that you stop any herbal medications or anything that you put yourself on over the counter 2 weeks before surgery. All those herbal medicines can actually interfere with the anesthetic that they give and can cause you to bleed or ooze more back in surgery. So the day before your surgery, they'll have you call in at 2 o'clock in the afternoon. They'll tell you what time you're on the surgical schedule and what time they want you to be here. The morning of your surgery, we ask that if they tell you to be here at 7 o'clock in the morning, that you please get here on time at 7 o'clock in the morning. The whole day is kind of scheduled 1, 2, 3 in a row. So if you arrive late, your surgery will be delayed or it may be canceled. When you come, we're going to ask you to go to the second floor to our SurgiCare pre-testing area. They'll put you in a room, give you a hospital gown to put on. Your nurse will take and look over your chart and your blood work. They'll start an IV on you. They'll do a shave and a prep of your knee or your hip. If you're one of our female patients, we ask that you don't shave your knee for about 5 to 7 days beforehand. We don't want you to happen to get a nick in your knee and start to harbor a microscopic infection. So we actually have special clippers that will take care of that when we do your shave and prep for you. About an hour before you're ready for surgery, we're going to take you up to the holding area. This is a room where our patients go right before they're ready to go back into the operating suite. There'll be a nurse from surgery and a nurse from anesthesia there. They'll hang your IV antibiotic. Your surgeon will come out and talk to you. He'll ask you which knee or which hip he's working on, and he'll take a special magic marker and he'll sign the site. It's his way of taking responsibility that yes, he knows you're his patient and he knows which knee or which hip he's working on. Your surgeon will take and do a pericapsular injection on you right before he inserts that implant in surgery. What a pericapsular injection is if you look at the picture, you can see that there's a joint capsule that surrounds your knee or your hip. The surgeon will actually take and inject the front, the back, and the sides of that joint capsule with numbing medicines during surgery. This will numb your knee or your hip and help a lot with your post-op pain control afterwards. But because of that, you'll have a weird feeling in that knee or that hip. So we are worried about your safety, and we don't want you to get up out of bed without help and without the walker until physical therapy tells you to do so. So we make you what's called a high falls risk. The way that we designate to our staff who's at high falls risk is you'll have a yellow bracelet on your wrist, yellow booties on your feet, and there'll be a red star magnet on the door frame to your room. That's how our staff knows to take extra special care with you and assist you when you get out of bed. Things that we want you to remember that make you at risk for a fall: if you're sick or in an unfamiliar place, like a hospital, if you have poor mobility or an unsteady balance, if you're over 65 years old, if you've fallen recently or before, if your footwear or your clothing doesn't fit well, if you're taking narcotics like you will be, or if you urgently need to use the restroom. That's actually the #1 cause of falls in the hospital, that people wait till they can't stand it anymore and they try and get up and rush to the bathroom. So that's something to keep in mind. Tips to prevent a fall. Here in the hospital, use your call bell and call early and wait for help to come. Just kind of look around and familiarize yourself with that room and that bathroom. Keep your surroundings uncluttered. If you would spill anything on the floor, let the staff know so they can wipe it up so it's not slippery for you. Always use your walker and keep it nearby. Always wear your yellow non-slip booties here in the hospital, or supportive shoes or non-slip socks at home. Don't get out of bed if you had that pericapsular injection until physical therapy tells you could do so. If you wear glasses, just put them on so you could see. In our showers, we have benches that fold down if you need to use those. And at night, use the call bell, turn the light on so you can see what you're doing in the room and in the bathroom. So this is actually a picture of a gentleman showing us how to sit for a spinal. The spinal will actually be done back in the surgical suite. We ask that you take and you tuck your chin all the way down to your chest, line up your shoulders and your hips, and kind of arch your back out like a mad cat on Halloween. That helps to open up your disc spaces so they can give your spinal easier. So once you're back in surgery and they've given your anesthesia and you're laying down and sleeping, the nurse who's in charge of the room will call a timeout. When we do this, everybody in the room, including the anesthesiologist and the surgeon, has to stop what they're doing and listen to what she says. She'll say, "This is John Smith. He belongs to Dr. David Smith, and they're doing a left total knee on him today." If anyone disagrees with the timeout, they can't go any further. So once that's confirmed, they'll prep you and drape you and do the actual surgery itself. So for those of you who are in knee replacements, the implants consist of 4 components. You see 3 of them here. So up above is that femoral component, which goes on the end of your thigh bone. Down below is a tibial component, and then just like you don't want to have bone rubbing against bone, you don't want to have metal rubbing against metal, so you see that plastic spacer or a tibial spacer in between. It kind of takes the place of that cartilage. It's a high-grade, high-wear polyethylene plastic. There's also a little button that will go on the back of your kneecap or your patella, and you'll see that here in a second in a couple of the slides. If you're one of our hip patients, there's 4 components to that implant as well. You see the long piece is actually your femoral stem. Then you have that round silver ball that replaces your femoral head. Same thing, you have a polyethylene liner, and then you have the acetabular shell. So those are the 4 pieces apart and together again. So there's 2 different ways to attach that metal to the bone. The first is what you call a cemented prosthesis. A cemented prosthesis is nice and smooth on the back. What the surgeon does is he'll mix up cement. It's kind of like the same consistency as toothpaste. They put that on the back of that metal, and when they insert it, it's the cement that's going to hold that metal to the bone. The second type is called a press fit prosthesis. It has like a grainy surface on it, kind of like rough sandpaper. So when they insert the press fit prosthesis, the tightness of the fit holds it in place, but what actually happens is the bone starts to grow into that porous surface or that grainy surface, and it's what we call bony ingrowth. Which of those your surgeon determines to use for you is up to him and all his years of knowledge and expertise. So let's talk about the steps of a knee replacement surgery. You see that diseased knee on the left, and in the after picture, the replacement on the right. So first what they're going to do is go up and address that femur, make their cuts, and put that implant on. And when they make the cuts, they're actually just little chips. It's not that big piece that you see in the middle picture there. Then they'll go down below to the tibia, do the same thing, get that diseased surface off, put that tibial implant and that tibial spacer on. Then they'll address that patella or that kneecap, take that diseased surface off of it, and put that little plastic button on that you see there on the right. So when they're all done with your knee, if you could see it, this is what it looks like. This is actually an artist's picture of a diseased knee and a regular knee, a replacement picture, and then an actual x-ray of a knee replacement afterwards. If you're having a hip replacement, you see the before and after picture as well. First thing they're going to do is go and address that femoral head and remove it. Then they'll go up into the socket or the acetabulum. It's called reaming the acetabulum. It kind of looks like a round cheese grater that goes up in there, gets all that diseased surface away, and takes it down to nice new bone that's going to accept that implant. Then they'll insert the acetabular component in that polyethylene liner, and then they have to ream the intermedullary canal of the femur, and then they'll insert that femoral component. So that long femoral stem goes down your intramedullary canal. Then they apply the ball to that femoral neck, and then they take and they reduce it or put it back into place. So when we're all done, you see an x-ray of that hip replacement on the left and the component pieces on the right. So when surgery is all done, the nurse anesthetist will take you to a recovery room, or what's called post-anesthesia care now. They'll monitor everything that they do in anesthesia. They'll have oxygen on your face to blow off the anesthesia. They'll start to watch that spinal recede from your hips to your knees to your ankles and away. They'll assess your vital signs, and once they consider you stable enough, they're going to take you up to our Center for Joint Replacement, where all of our joint replacement patients go. This is a picture of a knee and a hip patient afterwards, and there's a few things that I want you to note on there. The lady on the left had her hip replaced. She has ice on her left hip. All of our patients, we put ice on their incisions for swelling and for comfort. She has a pillow that goes from her knee to her ankle to gently bend her knee up, take some of the pressure off that hip. She has 2 pillows between her legs if she's a patient who has hip precautions. Those white sleeves that you see on her legs wrap around, and they have balloon chambers in those. What they do is they mimic the same muscle activity by balloons blowing up and deflating, and it helps prevent blood clots by pushing the blood back to your heart. So when you're in the hospital, you have to have those sleeves on while you're in bed to help prevent blood clots. The patient in the right picture is one of our knee patients. You'll notice that she has a dressing that goes from her toes all the way up to her groin. She also has a drain that's coming out of her knee. Some of our surgeons will use drains. She has that blue hose from that machine, is what we call a cold therapy machine. They actually look like little igloo coolers now, but that goes to a sleeve and it pumps slushy, icy water to it to ice down that incision. She has those same balloon sleeves on her legs to help prevent blood clots, and you see that balled up pillow under her ankle kind of helps the weight of her leg pull that knee back as straight as possible. We really have to work hard on the straightness of a knee after surgery. If you think about it, from looking at those pictures before the varus and valgus, that knee has been crooked for so long, it's going to take a while to rebalance itself and become straight afterwards. So you really have to focus on being straight while you're in bed here in the hospital and at home. If you're sitting in a recliner at night watching TV, put the legs of the recliner up, pull a pillow under your ankle so the weight of your knee pulls it back straight. As far as pain control goes, any hospital rates your pain on a scale of 0 to 10. 0 would be no pain at all. 10 would be the worst pain you've ever felt in your life. We utilize for our patients what's called a 3 or below pain drive. I don't like to take in buffalo our patients and tell them they're not going to have any pain after surgery, but we use multimodal analgesia, we use our pericapsular injections. We use a lot of methods to help our patients get their pain to below a 3 on that 0 to 10 scale. Most patients who come for joint replacement experience at least a 4 to 5 pain on a daily basis. If we can work with you and get that pain to below a number 3, we're going to be able to get all your education in you, all your physical therapy, and you're going to be able to go home quicker and safer than ever before. Once again, we consider our patients healthy patients. Believe it or not, you're going to be up out of bed walking about 2 hours after you get back to your room in the hospital after surgery. We need to get you active and up and walking as soon as possible to prevent any post-op complications afterwards. We like to dress our patients in their clothes from home. During the day here, it's going to be a very busy day after surgery. You're going to be up in that recliner, either walking, exercising, back in group therapy. It's a very busy day for our patients. Our group physical therapy we do twice a day at 9:30 in the morning and 2 o'clock in the afternoon. Like I said, you'll be up in that recliner early in the morning, out of that bed. We consider beds for sleeping in. Our patients need to get up and moving as soon as possible. So they spend the day in the recliners in their clothes. They go back to group therapy twice a day. The day after surgery, our patients will go back and have lunch together with the other patients and their coaches around 11 o'clock. So things that you want to think about after any surgery, things that we think about especially after joint replacement surgery to prevent. The first thing is blood clots. You run the risk of blood clots for about 6 weeks after surgery. So what we do is we have you on medicines to help prevent them for 6 weeks, and we also use a multitude of other measures to help prevent blood clots. Those balloon sleeves that I told you about, they're called SCDs, the medications that we'll talk about, and getting you up and moving you as soon as possible, and doing your foot and ankle pumps while you're in bed 10 times every hour. help prevent blood clots. The 3 most common medications that our doctors use to prevent blood clots, the first is aspirin. You'll take an aspirin twice a day for 6 weeks. Make sure that it's an enteric-coated aspirin to buffer your stomach, or a pill by the name of Xarelto. It's something that you'll take once a day for 14 days, and then they'll switch you over to an aspirin twice a day for the remainder of the 6-week period. Or if people have kidney problems, they may use a medicine called Lovenox. It's actually a shot that you'll give yourself in your fat layer in your belly. If you're on a special medicine called Coumadin before surgery, it's a special blood clot medicine. They'll restart that after surgery, and they usually bridge that medicine with something else while it starts to work. It usually takes a while for Coumadin to start to work in your body and a while for it to wear off after surgery. The second thing that we want to think about is respiratory complications. After you have anesthesia, after you're taking narcotics, you're not breathing as deep as you normally would, we have to worry about re-expanding your lungs. So things that we do to help prevent that is we teach you how to properly cough and deep breathe, how to use that Inspirex, is that machine that you see in the picture on the right. We want you to use that 10 times every hour while you're awake here and in the hospital. And when you go home, using that, it kind of guides you to take nice, big, deep breaths and fill your lungs as full as you can with air, so you can re-expand those lungs and open those alveoli and not run into any respiratory problems. And getting you up into the chair, getting you up and walking will help to re-expand your lungs as well. As far as monitoring blood loss, the morning after your surgery, we'll get a blood count in the morning and report that to your surgeon. Also, during surgery, you'll have special medicine to help prevent blood loss. And we actually have blood guidelines that, whether you know it or not, when you come and pre-test with us a couple of weeks before your surgery, if your blood level is within a certain range, your surgeon will start you on that iron, like I told you before surgery, to try and raise your hemoglobin. Right away the day of surgery, we actually start you back on those iron supplements while you're in the hospital to help your body rebuild that. We also believe in a good, nutritious orthopedic diet, high in fiber, high in fluids. Nutrition is very important after you have surgery, especially orthopedic surgery. It gives you the energy to get up and do your rehab. It helps those wounds heal themselves and your body fight off infection. We also utilize a bowel routine. Anytime you have anesthesia, you're taking narcotics, the peristalsis is the waves that move the food through your bowels. It slows way down with narcotics in anesthesia. And so we need to see that your bowels are functioning before we'll let you go home. But we start you on a bowel routine with laxatives and stool softeners. Like I said, we want to see that you have a bowel movement when you go home, but it's extremely important once you go home to monitor your bowel routine. Do whatever you have to do to get it back to normal. If you drink prune juice, if you drink hot water in the morning, anything that you have to do to get it back to normal while you're taking narcotics especially. If you have any needs for discharge, like medicine delivered to your pharmacy, any equipment needs for home, we have wonderful social workers and case managers. They'll take care of any of those needs for you, so you don't have to worry about anything like that. We'll also have occupational therapy come visit you, teach you how to do activities of daily living. Pictured are a few of the tools that you can use: a long-handled grasper, a long-handled shoehorn, or a sock aid. As far as physical therapy, when you get discharged from the hospital, all of our surgeons prefer that you have outpatient physical therapy as soon as possible, the week after surgery. It's your responsibility to choose and schedule your outpatient physical therapy. Your surgeon will talk to you about that beforehand. Some of them like you to wait about 7 to 10 days before they see you, and then they'll clear you for outpatient physical therapy. Others want you starting it within days after surgery. As far as your incision, you'll have a dressing on that looks like a thick Band-Aid. It's called an Aquacel. It's a special dressing that water cannot go through it. It stays on for 7 days. And then on the 7th day after your surgery, you're going to peel that dressing off. And we want you to take a good look at your incision. Your incision will be slightly reddened and slightly swollen for a couple of weeks after surgery. We want you to see what it looks like the first day that dressing comes off, because every day after that, you're going to change that dressing and you're going to compare it. You watch for any signs of infection. Signs of infection would be if it gets redder or more swollen, if those edges would open up or come apart, if it drains pus or it smells bad, or if you run a fever above 102, you call your surgeon who did your surgery. Those are all signs of infection. We have a 0 infection rate, and we want to keep it at a 0 infection rate. As far as blood clots, remember I told you run the risk of blood clots for about 6 weeks after surgery. This is a picture of a lady with a blood clot in her left leg. She's looking at you with her knees towards you. So you can kind of see how her leg is pinkish, reddish, and swollen. So be very astute and watch over your legs every day too. If you wake up one day and your leg is swollen like that, your entire leg, or a portion of your leg, or you notice a pea-sized lump or a knot that's very, very, very tender, you notify your orthopedic surgeon. It's extremely important that you watch for any blood clots. If you would happen to have a blood clot in your leg and a fragment would break loose and go to your lungs, it's what we call a pulmonary embolus, and signs and symptoms of that are sudden severe chest pain or shortness of breath. Anytime you exhibit sudden severe chest pain or shortness of breath, you don't mess around, you call 911 and get to the nearest emergency room. It's not that we like to scare our patients, but we like our patients to be well educated and well informed. So when you go home, we want you to continue your exercises that you were taught here in the hospital. Continue doing them 3 times a day. Work up to 30 repetitions of each exercise. We also want you to plan 3 walks a day in addition to all your normal activities. So if you left us walking 750 feet or 1,000 feet, when you go home, please take off from that point. Don't start back at 100 or 200 feet. Take off from the point that you left us, 750 feet or 1,000 feet. When you go home, your outpatient therapy, we already talked about how the surgeons like it to be done, and you need to talk to your surgeon about that as well. You can use ice at home. Many of our patients like to use Ziploc bags. They put ice in one and then put it inside of another Ziploc bag in case it busts. Or you can actually go and buy a 2-pound bag of frozen peas, and that conforms real nice and easy to your knee or your hip, and it stays frozen longer. As far as ice, a good rule of thumb is 20 minutes on, 20 minutes off. As far as hip precautions, like I said before, some of our surgeons believe in hip precautions, some of them do not, so you can ask your surgeon about that. But in class, I teach it because we have everybody's patients here. So the 2 basic things to remember about hip precautions is when you sit or bend, you should never go beyond 90 degrees. 90 degrees is like an L. So you can see the person sitting in the picture on the left, they're about 80 degrees. Your knees should never come up above your hips when you're sitting, or when you're bending, you can never bring your chest down towards your knees. Can't go further than that 90 degrees or an L. The second part of it, you'll see some pictures here about twisting and bending or lifting stuff off the floor, and that's occupational therapy and physical therapy will work with you and teach you about that. But the second part of hip precautions is crossing the midline of your body. So the markers for the midline of your body are your nose and your belly button. So if I had my right hip done, I can't cross my right leg across middle if you're a hip precaution patient. So once you have this joint replacement done, how do you get the best results? Do your exercises, watch your diet, keep your weight under control. Experts say, and different research says, that for every extra pound of weight you have on your body, it puts at least 4 to 7 times the amount of stress on those joints. So if I'm 10 pounds overweight, it's putting 40 to 70 pounds of excess pressure on those joints every time I take a step. To get the longest life out of your prosthesis, once again, maintain that healthy body weight, do your exercises, avoid high-impact activities. You can't become a downhill skier or a kickboxer. You have a new joint in your body. You kind of have to protect it a little bit. It's very important to tell any doctors, any dentists, any surgeons that you have a hip or a knee replacement in there. They'll all differ on the length of time after surgery they'll do it, but if you would have to have something, a procedure with one of them that would invade your bloodstream, they should put you on prophylactic antibiotics beforehand to help ward off any infections. If you do get any infections, please have those treated promptly. Even ear infections or urinary tract infections or sinus infections, you need to have treated promptly after surgery so they don't seed and go to that joint and ruin that joint for you. As far as reunions for our patients, every quarter we plan a reunion lunch for all of our patients and their coaches to come back, celebrate their success, show us how well they're doing, and educate them a little bit. And then before they leave, we ask our patients, how can we improve this program? And we get very good feedback from our patients, and it's just a nice thing to get everybody back and see how well they're doing. So the most important part that I guess I can impart on you is the end result of this surgery depends on you. Any good surgeon will tell you that doing the surgery is the easy part. What determines the success of this surgery is how you dedicate yourself to physical therapy and how you work really hard with your rehab. If you do that, you'll have a great outcome. If you don't do that, you'll just run into more problems down the road and you won't have great outcomes from surgery. So if you make a little bit of a commitment and invest some time, you'll see great results in the end. So some of our excellent outcomes, our average length of stay is 1 to 2 days. Some select few patients, we actually send those patients home day of surgery. We send our patients directly home after surgery and not to nursing homes or rehab centers. We like our patients go directly home. 99% of our patients are able to meet their quality of life goals in 4 to 6 months after surgery. And that's why you're having the surgery. Your knee or your hip bothers you and you have to give up doing things that you love. Our infection rate is 0, and we're very proud of that. Our transfusion rate for our patients runs between 0 and 1.5%. Our complication rate is between 0 and 1%, and our patient satisfaction is 95%. So these numbers are all well below, or our satisfaction is well above national averages for joint replacement programs. So in your pre-op book that you got from your surgeon's office is pictures and a list of the exercises. We actually want you to start doing your exercises now before surgery to strengthen both those legs before surgery. The first one is a very important exercise pictured here. Ankle pumps is really easy, but it's really important. You lay in bed and you point your toes up towards the ceiling and then point them down straight like a ballerina, and then up and down and up and down and pump that ankle. Here in the hospital, we want you to do that 10 times every hour and at home as well. Every time you do that, it'll help to rid fluid in your leg after surgery. It'll help that blood return back to your heart, and it tones those calf muscles that you need to get around after surgery. The second one is quad sets. If you look at the lady in the picture here, if she had her right hip or knee operated on, she's laying with that leg relaxed and outstretched. And what she does is she takes her knee and she pretends like she's pushing it down towards that bed and tenses it up. You'll see that your hip muscles or your quads will contract. You hold that for a count of 3 and then you relax it and keep repeating your quad sets. Straight leg raises, same thing. If she had her right side operated on, she's laying with that leg outstretched and relaxed, and then she takes her foot, lifts it about 10-12 inches off the bed, holds it there for a count of 3, and then slowly lowers it back down. Heel slides, same thing. If she had her right side operated on, you won't have the shoes on like she does, but we tell you to keep your heel on the bed and pretend like it's a sheet of ice, and then slide your heel up towards your bum, and then back down straight, and keep repeating that one. Coffee can kicks are the same thing as a straight leg raise. The only thing is, we ask that you ball up a pillow or a blanket or a coffee can and put it under your knee and then rest your knee on it for the exercise. It's the same thing as a straight leg raise. So you just lift your leg and your foot about 10-12 inches off the bed, hold it for a count of 3 and lower it back down. But by keeping your knee on that support, it's going to work different muscles in your leg. Windshield wipers or abduction exercises are just like they sound. You start with your legs in the middle, you swing your leg out to the side and you bring it back to the middle, just like a windshield wiper on a car. Glute sets are when you lay with your legs outstretched and relaxed. You take your butt muscles, you tense them up, squeeze them together real nice and tight, hold it for a count of 3, and then relax. So all of these exercises we want you to do on both legs. Start now before surgery, so it'll tone up those muscles that much more before surgery, and do them 3 times a day, at least 10 repetitions of each exercise. So our final slide is one of our slogans, replacing joints and restoring lives. We really believe in this slogan. The reason our patients come to us is because that knee or that hip hurts them on a daily basis, and they have to give up doing things that they love to do. That's why we set those goals with you. If you can't bicycle anymore, or you can't golf or bowl, or kneel on the floor and play with your grandkids. You know, we want you to get back to that healthy lifestyle and have a better quality of life. So that's why we do joint replacements for our patients. And we're proud to say that 99% of our patients reach those goals in 4 to 6 months after surgery. So thank you very much for listening to the pre-op class video. We can't wait to meet you, and we really hope that you'll enjoy your surgical experience here at Trumbull.